You are listening to Medical Backbone Radio, where we showcase the people and institutions who comprise Colorado's vital medical backbone. To learn more about us or to recommend a medical or health professional who merits our attention, please visit our website at medicalbackbone.com. That's medicalbackbone.com.
I'm Dean Rothbard, Managing Editor. Our guest on this edition is Steve Holloway, Director of the Primary Care Office at the Colorado Department of Public Health and Environment. Steve, glad you're with us today.
Thank you.
Let's start, if you would, by giving us an overview of your department. If you can, tell us what you're tasked with and how many people you've got at your disposal to help you pursue that task.
Sure. Well, the Primary Care Office is an office that exists in all 50 states and 4 territories. Our base funding comes from the Health Resources and Services Administration. And
that's national or local?
National.
National, okay.
So that's a typical grant that we'll have that funds sort of the base capacity of the office. Our primary charge is really assessing primary care access needs throughout the state and directing certain incentive programs to attract more providers into communities that have a deficit. So we typically look at physicians, nurse practitioners, and physician assistants in our primary care discipline.
I want to understand this better. You are a state institution with federal funding. Is that what it boils down to?
That is correct. We have a blended funding. So
Okay.
we do have some funding from the state as well. Our largest source of funding comes from private foundations in the state. About 5% of our budget is state. Maybe another 25% is federal, and the remainder comes from 3 large foundations in the state.
Again, what kind of either Army or SWAT team of people have you got at your disposal through your office?
So we have contracts with physicians, nurse practitioners, physician assistants, dentists, dental hygienists, psychiatrists, and psychologists. They each are providing a certain primary care service in a part of the state that has been recognized as having a shortage of healthcare professionals.
Okay, but you have a nuclear staff. You work out of an office where in the
State Health Department.
Health
We're one program among about 130 state health department programs, and our program again is charged with addressing barriers to primary care access throughout the state. So there are many other programs that I think are traditionally recognized as public health programs, like clean air, clean water, safe food, immunizations, disease control, those kinds of functions.
And to whom do you answer?
So I report to the governor, through a normal supervisory chain in the health department. But again, I have a fair number of grants that come from lots of different sources, and so I have obligations to each of those fund sources throughout the state to sort of perform as they've requested that we do under our grant agreements.
And your specific skill set, you're not a physician, is that correct?
That is correct.
Do you have public health training in your background?
My training is actually in biochemistry, so
Okay.
I found my way into public health because I was interested in policy, and it was just after September 11th that there was an expansion of bioterrorism and public health readiness activities that were funded from various sources. And so I came into the state largely to do an assessment of public health capacity and how ready was the public health system able to respond to an emergency threat to the public health. And so that's how I entered into the program.
On your LinkedIn page, which is where I got my biographical background on
Sure.
you talk about how in the state of Colorado, and I'm doing this from memory, so if I get it wrong, you'll tell me, but roughly 1 million people live without access to optimal health care. First of all, am I correct? That's the number?
That's the number. It's a fairly complex number, and it's sometimes challenging to communicate it to a lay audience. As we know, everyone needs some kind of primary care services, but if you're very healthy, you might only need a primary care visit once every 18 months or 2 years. If you're not well, or if you're elderly, or if you're expecting a baby, you actually need quite a bit more primary care services. So it can be challenging to sort of assess the primary care access needs of a community. We have a current analysis that's essentially a ratio of how many primary care FTE are available in a service area versus the population. And we can
What is an FTE?
A full-time equivalent.
Okay, a full-time equivalent.
Uh-huh.
And how does Colorado compare? You said all 50 states have a comparable primary care department. Somebody who's how do we compare in terms of maybe on a percentage basis, do our citizens have more access to primary care than other states? Are we in the middle? Are we at the top, the bottom?
We're probably better off than most states
Okay.
on average, but it's a challenging question to answer because it's variable throughout the state. So we can expect in certain suburban communities around Denver that access is very good for just about everyone. There are certain parts of the state, particularly in the south, central part of the state, where access is not very good. So the experience that you have acquiring a primary care visit is different depending on where you live in the state.
Now, I have to say, because this is a new subject matter to me, Steve, that I'm still confused. So I'm going to ask you to help me be less confused. You're not budgeted to provide direct care, correct?
That's correct.
So if I'm in a rural area, I can't come to your department either as a physician or as a patient and ask anything from you.
That's correct.
Okay. So how do you, and I'm not saying this in a confrontational way, I'm really just trying to understand, how does your office work to encourage better access to care throughout the state?
We have 3 different tools that we currently use. 2 are loan repayment tools, and 1 is an immigration incentive tool. So many physicians who leave their residency training will graduate with $150,000, $200,000 in student loan debt. Having that much debt often plays a very important role in where that physician determines that they'd like to practice. There's a lot of pay differential in the medical field, and so physicians might tend towards specialty careers so they can retire that student loan debt more quickly. What we're able to do with a combination of private and public resources is we can reduce that educational loan debt in exchange for service in an underserved community. We actually look for people who are likely to be committed to the community long term. We typically create a 3-year contract for a physician, and we'll reduce their student loan debt up to about $35,000 a year for each year of service. So a 3-year commitment could return about $105,000 against that student debt.
Okay, so if people are listening and they are themselves recent medical school grads, they're in medical school, or maybe they're a family member, then they can apply through your offices for this location and debt reduction.
Correct. That's correct. So we have an application that opens 3 times a year, and they submit an application. And what we look for is providers and physicians that have the attributes that we think are going to lead to long-term retention. We're not interested in creating sort of a Band-Aid solution. And traditionally, loan repayment programs for physicians have been perceived as it's great. We get a new physician, they come in for 2 or 3 years, they take a big bite of their student loan debt, and then they go back to an urban setting where they were before. Our goal is actually to sort of come up with more resilient solutions to these deficits.
How long in history have state or federal agencies actually tried to influence the location of physicians? Is that a program that dates back decades, or is that something relatively new? I always kind of had the sense that if you're a country doc, you're there just because you're a sort of a country doc.
Yeah.
But is it, in fact, is this a well-established, decades-old program?
It is. And actually, that country doc is just the kind of person we like to apply to our program, because we are trying to attract people to commit long-term. The National Health Service Corps is a federal loan repayment program that has existed since the mid-'70s, I think 75, 76. The state-based loan repayment program, I believe, has existed since about 1990, but it's only been in the charge of our office for about 2 years. There was some legislation at the state level in 2009 that had moved the program from the Department of Higher Education into the Department of Public Health and Environment. The rationale for that is that we really were taking more of a public health approach to the granting. And so I think we were able to lend some strength to the program by more actively looking for the kinds of physicians and other medical professionals who are really committed to the community long term, but just needed some assistance to sort of get established in a practice.
How many physicians in Colorado today have at some point taken advantage of this program? Do you have any idea what that number might be like?
I can tell you how many are taking advantage of it currently. I don't know long term. We have about 130 physicians and other providers in the state-based program, and about 270 in the federal program in Colorado currently. These are definitely high watermarks. Just 2 years ago, we only had 6 people in the state program and about 80 in the federal program. So it's been a big expansion over the last 2 years.